Hello and good afternoon. Just wanted to welcome you to our webinar. We're waiting for a couple of attendees, so we'll give them a minute or two, but just wanted to greet you at noon and let you know that we are here and we will be starting very shortly. If you have any questions in advance, please don't hesitate to use the chat function in Zoom, and we will be glad to stack those up and answer them as we can. Don't need to wait to the end. If you have a question, please feel free to send it up, and we will answer it right then. But we'll give you a couple of minutes just to gather the last stragglers, and then we'll get started. Okay, good morning, and afternoon rather, and welcome to Reducing Waste in Hospitals. My name is Lee Bryan. I'm the Director of Transformation Services with the Vermont Program for Quality in Healthcare, based out of Montpelier, Vermont. And what we want to do today is to go through the basics of lean in a hospital environment, but very specifically how it impacts the reduction of waste in hospitals as exemplified by the Institute for Healthcare Improvement's latest call to action, where they're reducing overall waste by 50%. So I wanted to just go through an agenda. Well, obviously the background, we'll talk about that in a second. The IHI put together this piece of work called the $1 trillion checkbook, which is why you've got that $100 trillion note on the right-hand side, which is real, by the way, just not in the United States. We're going to look at the associated call to action for the $1 trillion checkbook and what that has in terms of implications for you. We're going to look at waste types and impacts of how that transpires in your own hospital setting. And we're going to take a look at some very basic lean tools and how they can help. We're going to talk a little bit about how to work with VPQHC and summarize and then wrap up. At any point as you go through, please feel free to send questions up through the chat function in Zoom, and we will be glad to answer them. So the top issues confronting hospitals, there were a couple of studies done, and these were the results that popped up. Obviously, almost every hospital that you see or talk to has got financial issues, especially in this day and age of the move from to value-based payment from volume, and obviously that's causing some difficulties with the way that the finances are all balanced, and there's government mandates associated with them. You've got multiple other issues confronting them, doctor issues, organization-related concerns. And the question as a hospital becomes, how do you address all of those? It's a complex endeavor running a hospital, and obviously you've got multiple issues. So how do you address all of them? What we find is that you go back to basics, and this is one of the things that the IHI have done with the $1 trillion checkbook. This is the latest piece of work from the Institute for Healthcare Improvement. And the idea is that it quantifies waste and cost in the US healthcare system with one simple premise, that there is a huge amount of waste in the US healthcare system. They estimate, just based on the calculations that they've done, that it's over $1 trillion, and that's why, obviously, this is called the $1 trillion checkbook. They've broken it down into different major areas and obviously minor areas that feed those major areas. And as I'll show you a driver diagram that illustrates it all in a few minutes. But some of these are represented by some of these areas. So for instance, billing systems. I've just chosen a few at random. Spends roughly a quarter of their budget on billing, the average hospital in the United States. And in terms of actual numbers, what this means is you've got about 826 billion average annual hospital revenue, which translated means between 31 and 48 billion dollars in potential savings that you could get if you could take out about half of that non-value add work. So you can see the format of the calculations that they've done, and they go through piece by piece all of these different factors and quantify them. So it's an incredible piece of work, and I'd well recommend that you download it and take a look. This one talks about supply chains, and you've got a variation and unnecessary use of drugs and products. You've got some literature here, but basically you've got 2,300 US hospitals in the target population. They can estimate about about 11 million in savings for each hospital, which gives you a total estimate of 25.3 billion. These numbers really begin to add up from an overall system level. We've got things like soliciting staff and clinician ideas, and just even the lack of ability to harvest those really impacts the institution. So again, cost for estimated annual operational waste for a 46-bed unit was 843,000. Multiply that by the number of beds, and you end up with an estimated cost savings of $20.9 billion a year. As you can see, all of this is referenced through, so it's all thought through, and they've done a pretty good job of quantifying what all of this waste adds up to. So the question is, how do you feel about that? I speak to an awful lot of folks in hospitals and primary care environments day in, day out. And by and large, this is a pretty good summary of how most people are feeling. They're stressed, they're overwhelmed, they feel powerless and angry and anxious, all in the negative emotion quadrants. So the question is that sustainable, and what can you do about it? Well, hospitals are overloaded. We understand that. We know that. It's unfortunately the normal situation now. But what if, I want to take you on a little thought exercise for a second. What if you considered everything that goes on in this hospital building as work? Everything, like all of the different activities that happen for everybody every day. But you also understood that on average, about 30% of all the activity in that building was waste. So, you allowed that to continue unabated. But also at the same time, you were experiencing huge increases in demand, and you couldn't get more resources to handle the work. Wouldn't you look to reduce that waste and give yourself back the capacity that's being wasted on those wasteful activities? So let's take a look at what it looks like. Well, Lean tells us that there's 8 different types of waste, and they all impact the flow of the patient through care pathways in a hospital. You've got most of these contained in most care environments, but it is insidious, and by that I mean it's usually built up over a long period of time, usually years, and it takes a special way of looking at this to be able to not just reveal it, but also to identify it so that you can do something about it. There's multiple examples in the $1 trillion checkbook white paper. So the 8 wastes are basically overproduction, correction, waiting, transportation, unnecessary motion, inventory, excess processing, and underutilized people. And I'm going to go through a couple of examples of what these look like. So overproduction is doing something more or faster than's needed. You've got some actual examples. I've seen this particular one where you got 25% of surgical supplies picked for operations and then returned to the shelf afterwards. Not notifying food services of diet changes and discharges, so they produce unnecessary meals. Repeatedly printing face sheets for nursing units and training undertaken while not needed. And you can actually see the symptoms of this. Things like ordering unnecessary tests, things like excess beds or supplies, extra floor space being utilized, not following care paths, backups between departments. There's a lot of different symptoms that will point you to overproduction happening. Correction is the standard repair of a defective service or product, and there are many different examples of this. Things like replacing lost gowns in OR or nursing, pharmacy, refilling multiple dose medications, utilization review, infection control, risk management inspections. And there's a lot of the symptoms that point to those. Things like multiple quality control checks, patient returns. Obviously, that's a huge one because that's one of the main metrics that are measured, especially from CMS. High infection rates and falls. These tend to fall into the more standard quality metrics that hospital quality departments measure. Waiting is the idle time created when people wait for machines, or when people wait for people, or machines wait for people. Any kind of waiting, basically. Waiting on test results, outpatient lab draws taking a couple of hours, patients waiting for discharge placement is a classic in a hospital environment. And you see symptoms of this. Large waiting rooms are always a big giveaway. If there's a 50-person waiting room and it's full, you know that there's an unbalanced system. Idle people or machines is another classic. Excess transportation is any material or information movement beyond what's necessary. So moving things around from place to place. Things like walking intermittent samples to the lab, going to get prescriptions, finishing the patient chart, walking to the financial counselor. Things like every outpatient visit requiring a driver's license. And a lot of these symptoms point to deficiencies within the overall system design that mean that things have to be moved one way or the other, like inappropriate bed assignments on admission or having multiple information systems. Excess transportation, though, is moving things from one location to another. And a close analog of that is unnecessary motion. And that's when you've got people or equipment usually in one location, but they have to move around to get things or make things happen or reach for things. And good examples are anytime anybody searches for anything, like equipment. Things like inconvenient locations of fax or copy machines. You'd be amazed at how many times that we find fax machines being the bottleneck in particular workflows. And the symptoms, you can see things like excess patient transfer or movement, inconsistent work methods, long reach or walk distances, anytime there's a long lead time for anything. Inventory is any excess of goods or services in excess of what we call the demand profile, as in how much of it is used. And you've got multiple examples again. I was working in one hospital where one surgical cart alone had about $250,000 worth of sutures on it. And all of the sutures were on that cart, not just stored. You've got things like ED filling an entire dumpster from one outdated storage area. The amount of times that I've been in environments and found a room where it's just completely full of old stock or garbage or trash is unfortunately more common than not. And you've got multiple symptoms here, things like complex tracking systems, multiple forms, multiple copies, no standardization of supplies, multiple storage and handling locations. Inventory generally is, hospital systems err on the side of having too much rather than too little for obvious reasons. And so that can manifest in multiple different ways. Excess processing is when you've got an effort in activity providing no value to the patient. And examples are things like standing idly watching equipment operate, duplicating a physical assessment at triage and in the treatment area, placing the OR scheduling information in multiple different systems. And symptoms, you've got things like extra copies of forms, multiple signature requirements, manual distribution of numerous report copies, any long lead times, excess processing is usually one that is fairly common. Then we've got underutilized people, and that's using the wrong number and or level of staff for activities. Things like RNs doing OR tasks, which could be done by techs, or lab staff shortages at repetitive time. RNs doing repetitive phlebotomy. Anytime there's work piling up, and you've got other symptoms here, like usually multiple highly specific job descriptions. If I'm seeing highly specific job descriptions with very little room for maneuver, it's fairly common for that to result in underutilized people. You've got unmotivated staff and frustration. So there's a lot of implications for underutilizing people. So I want to take a quick 2 seconds here and just change directions. And I want to ask a question: who or what is the customer in the healthcare and hospital environment? And for those of you who've got access to the chat box, if you want to try putting in who you, or what you think is the customer in the hospital system, I'll give you like 15 seconds just to do it. Well, so far we've got a couple of responses indicating that the patients. A couple of ones where we're talking about my peers or other departments, and that's good. All right, so that's great. Let me dive in here because I've had a lot of different discussions about this in the past with multiple different environments, and from the standpoint of a systems thinking environment, as in the hospital as a system, to my mind, it's pretty simple. It doesn't exist without the patient. It doesn't have a reason to exist without the patient. So the patient is the eventual final customer. That's not to say that there aren't multiple stakeholders within the hospital. And obviously there are multiple groups within the hospital that are very definitely stakeholders. Things like professional groups, things like physicians, staff, laboratories, any of the ancillaries like diagnostic imaging, radiology. But all of that doesn't need to exist unless the patient is coming through that door. So, and I realize this seems simple, but from the lean standpoint, it's very critical. We always talk about patient-centered care, but our systems aren't necessarily designed for patient-centered care. They're traditionally designed around the way that a hospital is designed, is put into specific silos, for want of a better word. And the patient's flow through those silos is usually a secondary or even tertiary concern. So understanding that the patient is the customer is a really big deal. So I just wanted to clarify that that was what we were dealing with. There's a couple of folks called Bowen and Spear who did a wonderful piece of work called Decoding the DNA of the Toyota Production System in the Harvard Business Review in 1999, a long time ago now. And what they did was they translated the Toyota Production System in car manufacturing and worked out what all of that meant in terms of healthcare. And they came up with a definition of ideal healthcare that I use an awful lot, and I'll go through it just to help us understand what we're talking about here. So it's exactly what the patient needs, defect-free, one by one, customized to each individual patient, on demand, exactly as requested, with an immediate response to problems or changes, with no waste, and safe for patients, staff, and clinicians, physically, emotionally, and professionally. So translation, give the patient exactly what they need when they need it, with no defects or mistakes. But when those happen, react immediately and solve the problem, plus change the processes so that the problem doesn't happen again. Now, when you start looking at different measurement systems and indicators within hospitals, there are so many that it can make your head spin. But if you really think about it, what's the one best indicator of all of that happening? And it really boils down to one thing. How long does that patient stay in your hospital? The length of stay. Everything else can be tracked through multiple different levels to be able to affect that length of stay. So length of stay is a really big indicator for a hospital, and most hospitals, to their credit, measure it. So let's take a look at what that really means. Length of stay is affected by all of the different processes that happen to a patient as they go through the care pathway. And all of those processes are affected by the way that they're designed, the environments that they operate in, the equipment that they have to be able to perform it, the availability of trained staff to do it. And all of those are affected by what we in Lean call these particular building blocks. These are different sets of tools, techniques, and philosophies that we can use to be able to improve those processes as the patient goes through them. And it's organized in a house. We call it the House of Lean. We've got the basement where you've got the 5S system, visual and quality at the source. I'll explain some of these terms in a second. Further up, you've got standardized work, batch reduction, and teaming. Then you've got things like practice layout and OR layout, people involvement, and demand management by leveling. And then finally, you've got more advanced techniques like pull, and Kanban, which is just a word for signal. Then you've got cellular and flow designs, and then you've got equipment reliability. All of that is under a roof of continuous improvement. And you get into that house by this front porch that we've labeled value stream mapping. And this becomes a central concept, as we'll explain in a second. A value stream, if any of you have heard of that term before, it's all the steps, both value add and non-value add, required to complete a service process from beginning to end. So in our case, in an inpatient for the hospital, everything from the initial patient contact through the urgent care process, through treatment received, and then onwards into the hospital itself. And you've got, in this case, triage, registration, diagnosis, treatment. A very high level flow of what the patient experiences as they go through. Obviously, within each one of these boxes, there are multiple different levels underneath of how that is carried out. And that's an important concept we'll talk about in a second. But overall, that's what a value stream looks like. It's everything that happens to that patient as they go through from initial contact all the way through to, basically in a hospital case, discharge. And as I mentioned, there are multiple value stream levels. The one that we just talked about, this, is really a middle level, an L2, an operational level value stream. Because you can see that it's not complicated, but it does leave out an awful lot of the detail. But at the same time, it's not measuring an overall care pathway performance. It's measuring pieces of that care pathway performance. And so being able to categorize that in this middle level helps us to understand that better and understand that it is linked to both the strategic level measurements and also the tactical level measurements. So each one of these levels has their own individual set of measurement systems, but also ways of constructing that value stream. And they're all linked, they're nested basically. So that's important later on when we start talking about ways of measuring this. Here's a real one. This was actually the L2 and the L1 and L2 in this case. And it can look different depending on the various environments that you find. But as you can see, you've got these processes that are comprised of these individual ones underneath. And it starts to get complicated. As we all know, working in healthcare, it is a complicated thing. So let's take a look at what that means in terms of lean. So basic lean, and you can work with lean on multiple different levels. It can get incredibly complicated, but it really doesn't need to, especially not in a hospital environment. There's two different concepts that I use a lot. The first one is what we call setting the stage. That's thinking in terms of the workplace as being the stage of activity and setting that up so that the main workflows can be conducted with the least possible waste. And by that, usually there are four different sets of techniques that we use. First one is we call 5S. I'll talk about that in a second. As 5S, there's a component of that called point of use storage, or POUS, where stuff is located exactly where it's needed. Then there's setup reduction, which is making sure that if you're moving from one stream of value to another, that you can set up really quickly to be able to do one or the other, so you don't have to do batches. And that's the fourth one, batch reduction, which is making sure that when you are working with patients or samples or whatever it may be, you're not batching them too much. Once all of that's set, in terms of setting the stage, then we start talking about flowing value. And flowing value is really where you start thinking about how that patient flows through that value stream. So obviously you've got to do a value stream analysis to figure that out. But then you start getting into things like, how does the work actually get performed when you've got multiple different people performing it? So having an element of standardization really helps there. When you start getting into high volume environments, like for instance, a fast track in an ED, things like cell design really help, but also things like leveling of demand really help. So we're going to take a look at some of these concepts and see how they work. These pictures that are illustrated in these slides, by the way, are all real examples. So just so you're aware, we're not making this up. So the lean overview, well, what it is, the relentless pursuit of the perfect process through waste elimination. And you can see through this graphic, it really affects the overall, what we call the lead time, the overall time for a particular set of processes to happen. And you can see from the illustration that any of these, as we said from the value stream, it comprises work, which is value add time, and waiting or waste, which is non-value add time. In this case, they're colored in red and purple. Now, a lot of people misunderstand when we talk about lean, and they think that you're immediately looking at the way that particular value-added operations are done and trying to change that. And sometimes that does happen, but it's much, much lower down the priority list than addressing the waste in between those activities. So this illustration shows, you see the big blocks of waste before, and you see the smaller blocks of waste after. Obviously, the overall time has shrunk. So what it achieves? Well, higher patient satisfaction and experience. You got reduced patient time in the practice, the lower length of stay. You get more capacity out of your system. And there are lots of calculations that we do when we start getting into return on investment calculations that show just how much that capacity is actually worth. And of course, you're reducing waste as you go. So the idea behind value stream mapping is that don't map your practice or hospital, map the flow of patients, tests, and information through your practice or hospital. And that's an important concept, as we'll find out. Well, it's a detailed map that includes additional information like time taken, time wasted, resources used, and it identifies value add versus non-value add activities or waste. And it shows how that those processes operate from a system perspective. You saw with some of the examples earlier on, they can be quite simple or they can be quite complex. Here's another example of one. This one happens to be in a primary care setting. And as you can see, there are delays, which are represented by those upside down triangles. The processes themselves are linked, but there's multiple pieces of data that are gathered for each one. And you can see that at the bottom, you've got this ladder construct that adds them all up. There are ranges involved because obviously there's variability. We're not making cars or car parts or anything like that. We're talking about people, all of whom are different and all have different amounts of time that they need. So this would be another example of a value stream map that we would use to be able to model a practice. And from the value stream map, you can figure out issues that are impeding that patient flow. And literally, you're just making a list of these things to start off with. As you get through to here, you will start to think, okay, well, there's an issue with this particular delay. What's causing that? And you'll start to look at those issues and write them down. So how do you reduce that waste to construct what we call a future state value stream? The original value streams we've looked at already were all current state ones, as in what they look like right now. Constructing a future state map is really when you're visualizing what this is going to look like. And you're starting to look at things like, what are the issues? How can you construct ways of reducing the impact of those issues or eliminating those issues? And there are multiple different lean techniques you can use to do that. all of which are from that house of lean that we talked about. But the basic overall architecture of reducing waste really is around elimination of unnecessary processing steps, combining processes that are currently split, then sequencing those processes so that they flow in the right manner, and then simplifying the overall value stream. So working with those four different concepts, eliminate, combine, sequence, and simplify, is usually a good mantra to be able to figure out where you are when you're starting to implement lean philosophies. Let's take a look at some of these and how they operate. We got workplace organization and cleanliness, and we've talked about 5S before. It's a basically, I call this cleaning up on steroids. It's sort, set, shine, standardize, and sustain, and we'll talk about that in this next slide. But also part of workplace organization is visual management, where you've got these things called Andon and Kanban. And both of these are terms from the Toyota production system, but what they basically mean is Andon is just a visual indicator of a system condition that needs attention, which is what the little yellow light is for on the right-hand side. And Kanban is really a signaling construct. And by that, I mean, if you've got something that's about to run out, there can be a signal back to a supply store that will say, bring this amount of whatever it may be. That's one of the simpler ways of looking at it. Other ones are things like looking at patient movements from patient beds. You can have signaling systems through that. So, but the idea is to make them simple and visual. I talked about 5S, the sort, set, shine, standardize, and sustain. It's really one of the most basic lean principles, and what it means is you're just setting the stage so that you can take everything out of the workplace that isn't necessary to carry out the actual work, then set the remaining items that you need in a logical order so that work can flow. Make sure everything's clean, so shine it. But then standardize that from one area to the other. You typically, when you do 5S, you're starting off with one particular area, and you'll figure out different ways of coding information into the workplace. Things like color codes are a classic. The idea about standardization is to take all of those codes and use them to be able to illustrate that in different environments using the same codes. So you're standardizing the information between areas. And the last one is sustainability and making it a habit. And that becomes part of the cultural engineering component of 5S. Here's a typical set of supply shelves in a hospital before a 5S initiative. You can see it's pretty chaotic. There's no real indication of where anything is. And there's lots and lots and lots of inventory on those shelves. And this is afterwards. So everything's labeled. They've got way fewer items on the shelves. Quantities are specified. It's obvious what goes where. There's no clutter. These cards that are behind the bottles are all Kanban cards, which are signals. And everything's just easy to find. Let's talk about standardized work or reducing clinical variation. And again, these components that we're talking about, reduce clinical variation and 5S, so workplace organization, cleanliness, these are all related to the main constructs in the $1 trillion checkbook that we talked about for the Institute of Healthcare Improvement. So these are some of the ways that we can start to look at waste, that we can then start to realize some of those savings. Standardized work gets a pretty bad rap in healthcare, and it's unfortunate because it's just largely 90% of the time it is because it's misinterpreted. People think standardized work is a whole bunch of administrators coming in and telling you how to do the work. It's really not. What it is a lot of people that are very, very good at what they do getting together and figuring out what the best possible way is that they could do, taking all of their experience and putting it into one particular process, and then agreeing to all use that process. So it's actually created from within, it's not imposed from above. And then once you've got standardized work, you can use that as a baseline level of performance so that you can then start to work with continual improvement from there. Standardized work is a really powerful tool in this environment. So let's take a look at this call to action. And again, from the IHI publications, there were two. There's the $1 trillion checkbook, and there's also the call to action that's associated with that. The $1 trillion checkbook identifies the waste categories and the waste amounts that are involved there. The call to action talks about how to start reducing that. So both of them are worthwhile getting. They're very much associated, and I'd recommend that you download those from the Institute for Healthcare Improvement. The $1 trillion checkbook uses some straight quality tools. You've got a driver diagram here. Any of you that are involved in quality improvement are probably familiar with these. And what they've done is they've taken all of the waste that they found in the US health system and they've categorized it into 7 primary drivers, which in itself is an amazing feat. But then once you've got the primary drivers, they're looking at the secondary drivers that drive those particular conditions. And you can see them all here. I'm not going to go through them all, but it's been very well thought out. And the drivers themselves, the secondary drivers specifically, start to point to specific system conditions within the workplace that can be addressed using lean techniques and philosophies. So let's take a look at what that looks like. Well, reducing harm, and you'll see this format for the next few slides. Each one of these is working with one of the major primary drivers. The secondary drivers are going to be up here in bold, and then we're going to talk about some lean methods that can be used to impact these. So the first one is reducing harm. I have to forgive the artistic quality, by the way. I do not profess to be an artist, but it does break up the boring PowerPoint fonts. So reducing harm, they talk about conducting regular review of adverse and safety events to identify opportunities to reduce waste and identifying bold goals for the organization-wide strategic focus areas to reduce harm. How do you do that? Well, using lean methods, first of all, value stream mapping and multiple level value stream mapping are important to be able to establish the context for these safety events, adverse and safety events. Failure mode and effect analysis, FMEA, is a very useful tool when you start looking at a repetitive failure of resulting in some safety events. Run charts and process behavior charts are useful to measure them. But then when you start trying to solve the issues, using things like the plan, do, study, act cycle, and also if they're more complicated issues, the A3 problem solving methods are usually pretty effective when you're looking at reducing harm. Reducing workplace waste. Well, if you remember, there were 3 drivers, secondary drivers associated with that. Creating a culture of focus on the relentless pursuit of operational waste. So then now they're bringing in the construct of culture here. Improve operational efficiency through redesign and link to organizational focus on creating joy in work. And the lean methods, again, you need a value stream map to be able to understand the context of the workflow. And then when we start talking about improving operational efficiency, you've got a 5S system, solving problems using PDSA and A3, working out how different workflows interact and how to change from one to the other using setup reduction and batch reduction, understanding what the load is on all of those systems by using demand analysis and process behavior charts. There's also other components of this that would strictly fall outside of lean that you can use to be able to increase joy in work. Things like Hertzberg's theories of workplace organization and satisfaction are something that we use quite a lot to be able to view things in a slightly different way. Then we've got reducing clinical variation. This really gets into that standard work that we were talking about. It's engaging clinicians in activities to reduce unwarranted clinical variation and building linkages to the EHR for real-time smart alerts. And again, lean methods, multiple level value stream map is useful in this case to be able to understand the context. Understanding how different systems are set up and reducing the time that it needs to switch from one to the other is useful in setup reduction. Again, measurements using run charts and process behavior charts, and then problem solving using PDSA and A3. There's also some elements of error proofing, which is one of the more advanced lean techniques. Being able to design a system so that it's highly unlikely or impossible for you to make a mistake is really the concept behind that. Actively soliciting, staff and clinician ideas. Well, we're trying to equip and train the frontline staff to use key tools like lean and visual management and waste reduction, and engage in frontline staff in waste reduction idea generation, like through huddles or fresh eyes or teaming. And again, there's a whole list of lean methods that you can use to do this. Again, headed up by value stream analysis. You've probably seen a theme now. Whenever we're looking at a system, a value stream analysis is usually a pretty good idea to understand the context and the flow. But there's some more traditional quality tools involved in this one, things like swim lane diagrams and Pareto charts. And some of the other ones that we've been using are 5S, error proofing, batch reduction. Total productive maintenance is a more advanced lean tool also, where you're looking at equipment and making sure that it's maintained to the extent that it's always available. So you're reducing or eliminating breakdowns in critical machinery. Then you've got flow and cellular processing. So understanding how to set particular areas of work up so that the patients can flow the most effective way possible. Involving patients in identifying what matters to them. And sometimes that doesn't mean what you think it means. Like, for instance, nowadays, a hospital having open Wi-Fi might be one of the more critical things there. Parking surely can be an aspect of that. But then you've got the more traditional ones, things like outcomes, obviously. But the financial aspect of just bulk dollars, but also whether they're in network, and also obviously the length of stay. These are just some of the concepts. They're not meant to be exhaustive. So the idea is involving patients in co-design to identify the value add versus non-value added steps in the care process, and then soliciting ideas from those patients and families on how to reduce that waste. So identifying the context also with multiple level value stream analysis is important. And again, you're seeing the usual suspects here in lean methods of 5S, visual management, process behavior charts, PDSA A3, all the way through to error proofing at the end. Redesigning care to achieve the triple aim of increased population health, increased experience of care, and reduced per capita cost. We're looking at engaging in care redesign across transitions and building in the focus on waste reduction to test the change on the triple aim. And again, multiple different lean techniques that can be used in that particular activity to redesign that care. And the last one is engaging leadership to provide ongoing sponsorship. In my mind, this is one of the most critical ones. And a couple of the secondary drivers were incorporating waste reduction priorities in the system-wide and cascaded strategic plans. That's important to be able to keep this as a visible goal for the organization, and for everybody to understand that it is a desirable goal. And then creating an organization-wide visual management system to monitor efforts and outcomes. And again, we start to look at multi-level value stream analysis. When you talk about anything to do with visual management, you've got 5S and visual management. Process behavior charts to measure things, but also stuff like cultural engineering and leadership coaching, and using cascading metric systems are really important when you start to look at how do you engage leadership to provide ongoing sponsorship. So with all of that, the question becomes, you're in a hospital, you're trying to do something about this, where do you start? Well, the question I would ask is, where makes sense? And the first question I would ask is, where's the hospital's overall experience and ability level in improvement science, quality improvement? Is it an individual department? Are you doing it on your own or in a small group in your spare time? Do you have medium experience with a small dedicated time, or do you have a high experience where you're looking at some dedicated time there that's allocated? And the idea is that in the low experience ones, it's worthwhile starting off in an individual department, at some particular aspect that is causing problems. In the medium experience one, you can look at the whole patient care value stream and really look at how that patient moves through the hospital. And the high experience areas, you can do the patient care value stream plus all the ancillary streams. Things like how do you map the movement of samples and information to the lab? How do you map the taking of diagnostic images and reading and resulting from those? those kind of ancillary streams. So a lot depends on where your abilities and experience are in improvement science, but those would be the first indicators that I'd look for. It helps, really helps, to assess the hospital for both waste and culture. Any waste reduction requires a multi-pronged approach. I'm sure you're seeing that now. And assessments reveal the true picture of that waste. Waste, though, generally happens because of the accumulation of the results of culture. And so understanding that culture is very important in transforming for waste reduction. This can get complicated. It's really worthwhile getting outside help from some people that have done this and got some good results out of it. Multi-level value streams, again, these things are really important. They're worthwhile getting to know how to construct. And then once you're looking at that, you're going to end up with a list of improvement projects, and you need to rank these things because you're going to end up with a list of, in this case, 8. But I've had lists of improvement projects that are 30, 40, 60 improvement projects long. And of course, when you get overwhelmed with a list like that, nothing happens. So the idea is, let's put a very simple simplicity and payback improvement matrix so that we can figure out which projects to tackle first. The idea being, you've got literally an X and Y axis of complexity and effort, 0 to 10, and payback 0 to 10. And the projects that you're going to start off with are the ones with the lowest effort and complexity and the highest payback, and they're all in this top left quadrant. So this can be really useful in figuring out which projects to start off first. So what I would say is start improving. Take the time to quantify capacity and waste. Measure it often and start to utilize, if you're not already, that PDSA framework for problem solving. The more that you can do that, the more that becomes embedded in everybody's thoughts, and it becomes something that is more of the normal method of improvement. And be on the lookout for spread opportunities. By that, I mean, if you've made some improvements in one particular department and you're in another one and you happen to see that same opportunity, absolutely start to talk about it. And that comes onto this next one. Communicate, communicate, communicate. You know, this process improvement and quality improvement at this level, at the process level, is really a group activity. And you change hearts and minds in groups by communication. So don't be shy of communicating. Be the evangelist if you can. You know, obviously it's a delicate balance, but evangelism is not an uncommon thing in these arenas. And the last one is respect the hierarchy and get sponsorship. That's not to say that there aren't situations where just going and doing it is acceptable, but generally in a healthcare environment, getting a sponsorship from somebody higher up the food chain is usually a good thing. That's really the end of this particular presentation, and I wanted to thank you for listening. We have about 10 minutes left for any kind of questions that you may have. And what I'd like to invite you to do is to submit those in the chat box, and I'll be glad to answer any of those as we go. Well, it looks like that there's no questions forthcoming, so why don't we close this up? I want to thank you all for attending, and if you have any questions, I've left my contact information on here. If you need to get a hold of me, it's leeb@vpqhc.org, and you can get me on 802-229-2152. Thank you, and have a great rest of the day.